Hello, this is a video lesson on positioning of the digestive system, Part B. We're going to be talking about the contrast enemas as well as ERCP procedures. For the barium enemas, we're going to start with talking about the contrast media that's used. We could perform a single contrast or double contrast enema. The single contrast enemas, or the contrast media specifically used, is barium sulfate, or water-soluble iodine can be used in the case of a perforation, or air can be used to reduce an intussusception. When we use barium sulfate, there's going to be use of a low-density suspension, which is a 15 to 20% weight per volume. Double contrast methods are going to use barium sulfate and air. In that case, the barium sulfate suspension is a high density and it's 80 to 100% weight per volume. With the double contrast enema, there are two different procedures that can be performed depending upon the protocol for that facility. In the single contrast procedure, the radiologist selectively injects both barium sulfate and gas. In the two-stage procedure, the radiologist injects barium sulfate, but after evacuation of the barium, then air is injected. The positive contrast, whether we use barium sulfate or water-soluble iodine, is going to display anatomy, the tonus of the colon, and most abnormalities. The negative agent, which is the air, is going to distend the lumen of the bowel to visualize the barium-coated mucosal lining of the colon. Double contrast or air contrast studies demonstrate small intraluminal lesions such as polypoid tumors. For patient preparation for the barium enema, the large intestine must be completely emptied of all contents. Retained fecal matter can simulate polypoid masses, as can be seen in this image, in which a patient was not with their colon was not completely cleaned. So bowel cleaning is completed with either complete intestinal tract cleaning kits, GI lavage preparation, or cleansing enemas, or a combination thereof. With patients with the patient prep for patients with severe diarrhea, gross bleeding or obstruction is limited. So the contrast enema equipment includes the soft plastic enema tips and the enema bags, and those are commercially available in different sizes. Smaller tips are necessary with patients with strictures, fissures, inflamed hemorrhoids, or other anal abnormalities. And these are just pictures of the tips to which we're referring. The last two tips that I circled, this one here is with the balloon that's not inflated, and this is with the balloon inflated. So, and here's a balloon that's inflated down here as well. Some of them have balloons and some do not have balloons. So with the balloon cuff, the enema tip is inserted just before the exam, and then the balloon is inflated with 90 milliliters of air after insertion. There is a potential for intestinal wall damage if inserted or inflated improperly. Enema bags themselves have a 3-quart or 3,000 milliliter capacity. 100 to 2,000, 1,000 to 2,000 milliliters is mostly used. And then we have the tubing to which these enema tips are connected, and that's about 6 feet long, and they have a flow control clamp or clip. And so that's what's shown here, this tubing in this picture. So we want to, as far as the barium suspension, and we're putting the suspension which is shown here, and we put it into that bag, we want to follow manufacturer's instructions. Temperature, the suspension should be below body temperature. It can cause injury if it's too warm, and higher temperatures are uncomfortable for patient and decrease retention. And by the way, here's the clip to what we were referring in the previous slide also that holds the barium in the bag until you're ready for the study. Preparation and care of the patient. Patient cooperation is the key to this study. So we're going to want to explain the patient's role in the exam. We're going to instruct the patient on ways to minimize discomfort during the filling, which is keeping the anal sphincter tightly contracted against the tubing. Relax abdominal muscles is important. Deep oral breathing to reduce cramps and spasms. Communicate cramping so that filling can be slowed or stopped. It's essential to allay fears and embarrassment and keep a bedpan available just in case. Provide adequate draping to make sure the patient is covered for increased comfort. Be aware of their strength, their age, and their condition. Preparation may cause weakness, so you may have to have extra care with elderly and if infirm patients that they need extra attention when they're going to the restroom. Let the patient know about the call button in the restroom and respect patient privacy, but inquire frequently on your patient when they're in the restroom. So for enema tip incision, we're going to use the Sims position. Then we're going to instruct the patient to turn on their left side. They're going to roll 35 to 40 degrees and rest on the flexed right knee above and in front of the flexed left knee. This is going to relax the abdominal muscles, decreases abdominal pressure, and aids in relaxation of the anal sphincter. You want to adjust the IV pull so that the bag is no higher than 24 inches above the level of the anus. We want to expose the anal region only so that the patient is then completely covered, but that's the only part that's exposed. We want to run barium into the basin to remove air from the tubing. You want to lubricate the tip. Instruct the patient then to take deep breaths. Elevate the right buttock laterally, and during expiration, insert the tip gently and slowly. Direct anteriorly 1 to 1.5 inches and then slightly superiorly. And you want a total distance for that tip being moved into the rectum of no more than 4 inches. Never force insertion. So after the tip is inserted, hold it in place while the patient turns into the supine or prone position, whatever the protocol is for that facility, and then inflate the retention cuff. The single contrast enema, we're going to introduce the patient to the radiologist. On request, release the clip to allow barium to flow. Flow is stopped frequently per the radiologist's request, and we want filling as seen or viewed on the fluoroscopy. The radiologist instructs the patient to rotate to visualize all aspects of the bowel. The radiologist takes spot radiographs as needed, and they perform overhead images per protocol. We want to deflate the retention balloon, remove the enema tip, and assist the patient to the restroom and expel as much of the barium as possible, provide a bedpan if needed. Post-evaluation images, we'll talk about those too, can be taken. Sometimes it'll be 1 or 2 images that can be taken after they evacuate, and that's to check the mucosa. So make sure you let your patient know that they may not be able to leave right after they complete emptying their colon. If evacuation is inadequate, the patient may need to be given a hot beverage to stimulate evacuation, and then repeat the post-evacuation image as requested. So for double contrast exams, it's really the same process for us, except the radiologist just administers 2 contrast agents. ACR does have the following criteria to ensure consistent quality in double contrast BEs. Is that the entire colon is sufficiently coated with barium, the colon is well distended with air, each part of the colon is demonstrated in the double contrast on a minimum of 2 images taken in different positions when possible, and that's in your overhead images you'll be taking. And then there's demonstration of the entire colon, proven when the ileocecal valve, terminal ileum, or the appendix is seen. The overhead projections can vary from place to place, but all of the projections that you could perform are provided in this PowerPoint. So the first one is the PA projection. In this case, the patient is prone. We're to center the mid-sagittal plane to the image receptor, and the image receptor is centered at the level of the iliac crest. We're to suspend respiration. The image receptor is centered at the level of the iliac crest, like said before, and we're going to have the collimation open to a 14 by 17. And what this projection does, it shows the entire colon with the patient prone. And here's the image of the colon. So here's the ascending colon on the right, the descending colon on the left patient side. And so here again, here's the ascending, and here's the descending colon. So it just shows the entire colon. Here's the transverse colon. The flexures are covered up, they're not open, in other words, and there's the sigmoid colon down here. So it's showing the overall survey of the entire colon. On the PA projection for the evaluation criteria, we're going to see the entire colon, including the flexures and the rectum. 2 images may be necessary for hyperstenic patients. The vertebral column is centered so that the ascending and descending portions of the colon are included. And there's proper penetration of the contrast medium. This is a double contrast enema in this picture. Now the PA axial projection is with the patient prone. We're going to center the mid-sagittal plane to the image receptor. I'm going to suspend breathing. Our central ray is going to be 30 to 40 degrees cauded to enter at the level of the ACES. Our collimation can either be 14 by 17 or 10 by 12, depending upon protocol. And what we're going to look at as far as structures shown are concerned is the rectosigmoid region of the colon. That's the purpose of the PA axial. So when you have a patient and we're doing a PA axial and you can see the butt, you're going to angle toward the buttocks. Caudad. So 30 to 40 degrees caudad. On the AP projection, which could be performed in place of or in lieu of the PA projection, instead the patient is supine, the patient is centered the exact same way. We're still going to do suspend respiration. And then we're going to perform this with 30 to 40 degrees cephalad instead. And so if you can see their face, you're going to angle toward their face. You're going to perform this center specifically 2 inches below the level of the ACES. Now you can once again use 14 by 17 or 10 by 12 collimation, but you're going to have the same structure shown as you had on the PA axial projection. So one of the two can be performed. On either image, you're going to see the rectosigmoid area centered to the image when a 10 by 12 exposure field is used. The rectosigmoid area with less superimposition than the AP or PA because of angulation of the central ray. So you're able to move the colon up out of the way and we're able to focus on that sigmoid colon. The transverse and the flexures may not always be included. Now we have the AP oblique projection, which is a supine position. The patient's left arms by their side, the right arms across the upper chest. You want to rotate the entire chest, not and body at the same time. Flex the right knee for stability. Place a sponge behind the patient's back. And we're doing a 35 to 40 degree oblique. We're going to center the patient's body to the midline of the image receptor, and we're going to center at the level of the iliac crest again. We're going to suspend respiration. We're going to have our central ray perpendicular to the image receptor. We're going to enter about 1 to 2 inches lateral to the midline on the elevated side at the level of the iliac crest. Our collimation is 14 by 17. On the LPO, which is what is shown here, we're going to see the left colic flexure and the ascending colon and the sigmoid portion of the colon. So what you're seeing is the side furthest from the image receptor on the AP oblique. So looking at the AP oblique, the LPO position specifically, we're looking at the right colic flexure, we're looking at the ascending colon, and we can see the sigmoid. But we're focusing on the right side of the colon with this right colic flexure and the ascending, so the LPO shows the side furthest from the image receptor. Here's an AP oblique again. This time the patient is again supine, but they're in an RPO. We're going to have the exact same positioning that we just had for the opposite one. We're going to center the same location and the same respiratory instructions as well. We're even going to have the same central ray information that we're going to center about 1 to 2 inches lateral to the midline on the elevated side at the level of the iliac crest again. So just looking at that location. But this time we're doing an RPO, so we're going to see the side up again, which is the left now. So we're going to see the left colic flexure and the descending colon. On this image, we see the entire colon, but that left colic flexure is now open, and we can see the descending colon is what we're focusing on. Now, if we do the PA obliques, we're going to see the opposite thing. We're going to see the side down, the side closest to. So we're going to do the exact same oblique with flexing the patient's knee, arm behind the side. The entire body is in that oblique. So it's not just a part of it, it's the entire body. We're going to center to the level of the iliac crest and suspend respiration. We're going to enter about 1 to 2 inches lateral to the mid-sagittal plane on the elevated side at the level of the iliac crest again. So at the same level as we were before. 14 by 17 collimation. So we're going to see the side down, and this is an RAO, so we're seeing the right colic flexure, the ascending colon, and we do see the sigmoid portion of the colon in this one as well, just like we saw in the LPO. So this position shows the same thing that we saw in the LPO earlier, because the LPO showed the side up, the RAO side shows the side down. And so here we are with the right colic flexure, the ascending colon, the cecum, which is also shown here as well. It's just on that same, still on that same side. And we can see the sigmoid as we saw before. In the LAO position, which is what is shown here, the patient is prone. We're going to have the same instructions we had for the RAO, and we're going to use the same central ray directions as well. But this time, since we're doing an LAO, we're going to see the side down, which is the same as if you were doing an RPO. The RPO shows the side up, the LAO shows the side down. So we're going to see the left colic flexure and the descending colon in this case. And so here we go. Here's the left colic flexure that's open and the descending colon that's shown on this image. So here's the RAO versus the LAO colon. The RAO shows the right side, which is the right colic flexure, the descending colon, and even the cecum. It does happen to show the sigmoid too. It's the only thing that's odd about it. The LAO, on the other hand, shows the left side, which is the left colic flexure. It opens it up, the descending colon, and that's the idea behind these. And in place of the REO, you could do an LPO, and in place of the LAO, you could do an RPO. Here's the lateral projection. We call it the lateral rectum because that's all we're imaging is just the rectum. So it's a lateral recumbent position. We're going to center the mid-coronal plane to the image to the image receptor. We're going to flex the knees slightly for stability and put a support between them that you can see in the image. We're going to put a piece of lead behind the patient on the table. We're going to adjust the image receptor at the level of the ACES and suspend respiration. We're going to central ray is going to be perpendicular to the image receptor to enter the mid-coronal plane at the level of the ACES. So the collimation is a 10 by 12, and we're going to see the rectum and the distal sigmoid portion of the colon. So like I mentioned, it's called a lateral rectum image, and that's what we're seeing is the rectum. And that's all we see. We don't want to see anything else. This is just a 10 by 12 image. We're looking at the rectosigmoid area is the important thing in the center of the image. So here's the rectum, and here's the sigmoid. So the superimposed hips and femora are not included, and you can see this is the enema tip if you're wondering what that is. Now the decubitus positions, we do 2 decubitus positions possibly, especially with air contrast enemas. They're used to show the side up. I purposely put that crooked. The air inflated portion of the colon is a part that's of importance, the air part. So where does air go? Air always goes up. Barium is a suspension, so it's going to go down. On the AP or PA projection, right lateral decubitus position, we can see our patient's currently in the AP projection. It's not that you couldn't have done a PA projection, it's just an option. The key is that he's in a right lateral. He has, we have centered our mid-sagittal plane to the image receptor, and we've adjusted the center of the image receptor to the level of the iliac crest. Or to suspend respiration, the beam is horizontal and perpendicular to the image receptor and is going to enter the midline of the body at the level of the iliac crest. The collimation is still 14 by 17, and the important thing is the structure shown. The right lateral decubitus shows the side up, which is the air side up. So what we're going to be looking at is going to be the upside or the medial side of the ascending colon, because that's the side that's up, and the lateral side of the descending colon when the colon is inflated with air. To show that in the image might be easier. So taking a look at that, we're looking at the air side up. So think about this as the left side is up, the right side is down. So we're looking at the medial side of the ascending colon and the lateral side of the descending colon is what our goal is. On the AP or PA projection, now this time they happen to have the patient in the PA projection, left lateral decubitus position. The air inflated portion of the colon is still important, where patients in a left lateral are centering our mid-sagittal plane to the image receptor. We're going to adjust our center of the image receptor to the level of the iliac crest. We're going to suspend respiration. Now this time our left side is down, so it's a left lateral decubitus, and our right side is up. We're going to center at the level of the iliac crest again. We're going to have a 14 by 17 collimation. And this time we're going to have the contrast-filled colon, in which we see the lateral side of the ascending colon, because that's the side that's up. And we're going to see the medial side of the descending colon, because that's the side that's up on the other side of your colon. And here we go. So this is the right side that's up. Here's our left side's down. So we're seeing the lateral side of the ascending colon and the medial side where there's air of the descending colon. And here's the right lateral decubitus versus the left lateral decubitus, just showing that here's our left side, this is our right side, and then right and left is again. Looking at the air-filled sides are the sides that are up, air-filled side that's up, and here's our air-filled side that's up over here, and there it is over here. So keeping in mind that this is the descending colon, the lateral side of the descending, the medial side of the ascending, and for the left lateral decube, we're looking at the lateral side of the ascending and the medial side of the descending. The AP or PA projection can be used for post-evacuation. In this case, the patient's either supine or prone. We're going to have the mid-sagittal plane aligned to the image receptor. We're going to center at the level of the iliac crest again. Suspend respiration. So our central ray is going to be perpendicular to the image receptor at the level of the iliac crest, and we're going to keep our collimation maintained at 14 by 17. Again, this shows the entire colon. It may require 2 exposures depending upon the size of your patient. We're to perform an AP or PA projection, which is a post-evac image. Prior to this, they're going to have the patient's going to take their time to evacuate. They're not all the barium will not evacuate, though, could take up to 48 hours or longer. Before the patient evacuates, let them know that it's going to be coming out white, and that they'll continue to have expel that white for a couple days. Check on your patient while they're in the restroom to make sure they're doing okay, and then show the radiologist the post-evac image before the patient leaves. Some places just do the AP and the PA projection. Others also may do a lateral rectum post-evacuation also. Okay, so last but not least is the biliary tract and the gallbladder. So here's some word roots that are important for us. The term coli means bile. Cysto means bag or sac or bladder. Colidoco means bile duct, so colidoco means common bile duct. Cholangio technically is not bile ducts, it's technically bile vessels. And then cholecysto is the gallbladder. So we do a cholecystectomy, that's a removal of the gallbladder. So the ERCP is referred to as or called the endoscopic retrograde cholangiopancreatography. What we're going to do is we're going to have a surgeon who's going to perform an endoscopic procedure, but we're also using radiography at the same time. We can see the patient is either supine or they could be in an LPO position. They're going to have the scope down their throat and going down into the duodenum. It's going to be used to diagnose biliary and pancreatic pathologic conditions. It's a useful diagnostic method when the biliary tracts are not dilated or when no obstruction exists at the ampulla. And it's often indicated when the clinical and radiographic findings indicate abnormalities in the biliary system or the pancreas. So this ERCP, as I mentioned, we're going to have an endoscope that's passed through the mouth into the duodenum under fluoroscopy. They're going to ease the passage to the endoscope and the patient's throat is sprayed with a local anesthetic. After the endoscopist locates the hepatopancreatic ampulla, which is called the ampulla vator, there's going to be a small cannula passed through the endoscope and directed into the ampulla. When the cannula is properly placed, contrast media is going to be injected into the common bile duct. The patient can then be moved, fluoroscopy performed, and spot images that are taken. These are some images taken from an ERCP in which we can see the endoscope is displayed on the images. We can see the common bile duct, which goes up here. The patient's for gallbladders removed, that's what these little staples are. That's where the gallbladder had been removed. And this is called a cystic stump now because they cut the cystic duct when they removed the gallbladder. From this point up, we're going to have the common hepatic duct, and then there's the right hepatic duct and the left hepatic duct. Going across here is the pancreatic duct. So just thought I'd show you some images. And that concludes the lesson on the digestive system. Have a great day.